Picture this: gout, that excruciating condition triggered by crystals forming in your joints due to excess uric acid, affects millions worldwide and often leads to lifelong pain, swelling, and even permanent damage to bones and cartilage. But what if there was a safer, more effective way to manage it without the drawbacks of existing medications? Join us as we dive into the groundbreaking first-in-human study of ABP-671, a promising new drug that could change the game for gout sufferers. Introduction. Gout stands out as a persistent inflammatory disorder rooted in elevated levels of serum uric acid, SUA, stemming from issues in purine metabolism or the excretion of uric acid itself. This buildup can result in chronic joint inflammation, the formation of tophi, those gritty, crystal-laden masses encased in inflammatory tissue that can erode bone and cartilage over time, and other complications if not addressed. Prevalence rates vary widely, from under 1% to as high as 6.8%, depending on the population and research methods, with incidence figures ranging from 0.58 to 2.89 cases per 1,000 people annually. To keep things simple for beginners, think of uric acid as a waste product from breaking down purines in foods like red meat and certain seafood. When your body can't flush it out efficiently, it accumulates and forms sharp crystals that cause the intense pain associated with gout flares. Managing gout often involves combining dietary changes and lifestyle tweaks with urate-lowering therapies, ULTs, aimed at maintaining SUA below 6 mg per deciliter or even 5 mg per deciliter in some cases, to prevent those damaging crystals. Current ULT options include xanthine oxidase inhibitors like febuxostat and allopurinol, URAT1 inhibitors such as benzbromarone, probenecid, and the now-withdrawn lesinuride, plus urate oxidase drugs like pegloticase. However, these come with significant drawbacks, including suboptimal efficacy, serious liver and kidney risks, and for febuxostat, a heightened chance of cardiovascular issues. This has sparked an urgent search for better alternatives. Enter ABP-671, an innovative URAT1 inhibitor crafted by Atom Therapeutics Company, Limited. By targeting the URAT1 protein, mainly found in the kidney's proximal tubules, where it plays a key role in reabsorbing about 90% of uric acid, ABP-671 works to curb this reabsorption and boost uric acid excretion through urine, effectively lowering SUA levels. Lab tests on kidney cells from dogs engineered to express human URAT1 revealed ABP-671's potent inhibition, with an IC50 of just 0.04 μm, far surpassing benzbromarone's 0.14 μm and lesinuride's 24.36 μm. Animal studies in rats with high uric acid showed quick absorption and notable drops in SUA and blood urea nitrogen at doses of 15 and 25 mg per kilogram daily. This research sets out to scrutinize ABP-671's safety, tolerability, pharmacokinetics, how the body handles the drug, pharmacodynamics, how it affects the body, and the influence of food on its performance in single and repeated doses for both healthy individuals and those with hyperuricemia. Patients and methods. Study design. Conducted in the United States, this investigation into ABP-671 comprised 3 distinct segments, all involving healthy volunteers and participants with elevated uric acid. Single ascending dose, SAD, study. This phase I trial, single-center, randomized, double-blind, and placebo-controlled, focused on the safety, tolerability, pharmacokinetics, and pharmacodynamics of escalating single doses of ABP-671 in healthy adults. Dosing began at 0.1 mg, progressing to 0.5 mg and 1 mg, with 2 placebo recipients and 6 active drug participants per group. After an overnight fast lasting at least 8 hours, each subject took their assigned dose with 240 milliliters of water. Groups of 8 participants each, 6 receiving ABP-671 and 2 getting placebo, were dosed in a blinded fashion while fasting. To prioritize safety, a sentinel approach was used. 1 participant from ABP-671 and 1 from placebo were treated first in each cohort. Only after 72 hours without issues did the rest proceed, with 5 getting ABP-671 and 1 placebo. Once a cohort finished dosing and had at least 7 days of observation, the next higher dose was tested on the initial sentinels. See Figure 1a. Multiple ascending dose, MAD, study. This phase IB effort, randomized, double-blind, and placebo-controlled, examined the safety, tolerability, pharmacokinetics, and pharmacodynamics of increasing daily doses of ABP-671 as a 10 milliliters solution in 3% sodium bicarbonate mixed with 480 milliliters of water for 10 days in hyperuricemic adults otherwise in good health. Eligibility required SUA levels of at least 7.0 milligrams per deciliter for men and 6.0 milligrams per deciliter for women. The drug was taken once daily following an overnight fast. Each of the 3 dose cohorts, 0.2, 0.5, and 1 milligram daily, enrolled 9 participants, 7 on ABP-671 and 2 on placebo, all dosed QD while fasting. After a cohort completed 10 days of treatment plus 14 days of follow-up, the subsequent group began. Dropouts unrelated to adverse events were replaced. Figure 1b. Food effect study. In this open-label, single-dose, randomized crossover trial at Pharmaron Clinical Pharmacology Center in the USA, 12 healthy adults were assigned to sequences A, B, or BA. Sequence A involved a 1 milligram ABP-671 tablet on an empty stomach, followed by B, fed state, or vice versa, with each phase separated by a 4-day washout. Doses were taken with 240 milliliters of water, Figure 1c. Ethical considerations. All procedures adhered to the Declaration of Helsinki and ICH Good Clinical Practice Guidelines. Institutional review boards, Advera and Integ Review, approved the protocols, and trial registrations included NCT 039060006 for SAD, NCT 04060-173 for MAD, and NCT 0430339 for food effects. Participants gave informed consent before any activities. Study population. SAD study. Inclusion. Ages 18 to 45, medically healthy per history, exams, ECG, and vitals. SUA 4.0 to 5.5 mg/dl, men, or 4.0 to 5.0 mg/dl, women. BMI 18.0 to 32.0 kilograms per square meter. Weight greater than or equal to 50 kilograms. Exclusion. Major illnesses or mental health issues. Kidney stone history or suspicion. Recent drug/herbal use, 14 days, including HRT for women. Positive drug screens. Major surgery in 3 months or other disqualifying factors. MAD study. Inclusion. Hyperuricemic but otherwise healthy. Ages 18 to 65. SUA greater than or equal to 7.0 milligrams per deciliter. Men, or greater than or equal to 6.0 milligrams per deciliter. Women, based on screening averages. BMI 18.0 to 35.0 kilograms per square meter. Weight greater than or equal to 50 kilograms. Exclusion, similar to SAD, plus recent arthritis or gout flares, kidney stones, drug use within 3 weeks, prior investigational drugs, including ABP-671 and other relevant conditions. Food effect study. Inclusion, ages 18 to 60, healthy per checks, SUA 3.7 to 7.0 mg/dl, men, or 2.3 to 6.0 mg/dl, women. BMI 18.0 to 35.0 kilograms per square meter. Weight greater than or equal to 50 kilograms. Exclusion, parallel to others, with added restrictions on bariatric surgery, malabsorption issues, alcohol screens, and more. PK and PD assessments. Blood draws, about 5 milliliters for PK, 2 milliliters for PD, and urine samples, for PD, followed timelines in supplementary table S1. Drug levels were measured via validated LCMS/MS parameters were computed using non-compartmental analysis in Phoenix Win-Non-Lin 8.1. Analysis of food effects. Variance analysis and linear models assessed log-transformed AUC0, T, AUC0, INF, and Cmax, accounting for fed versus fasted states, sequence, period, and subject. Geometric mean ratios, GMRs, With 90% confidence intervals, CIs were calculated. If CIs